Good morning. Today's topic is abdominal incisions. We are going to learn about the general principles that has to be followed while placing abdominal incisions, the classification of abdominal incisions, the commonly used incisions, and something about incisional hernia. So coming to the general principles. So while you place the surgical incisions on the anterior abdominal wall, there should be adequate exposure. You have to think about all the organs that have to be exposed and the incision has to be placed accordingly. Then the nerves and blood vessels of the anterior abdominal wall should be protected. Then the muscles must be split in the direction of the fibers. That is in order to promote healing with minimal scar formation. So that is why the muscles are split in the direction of their fibers. Then muscles and viscera are attracted towards their neurovascular supply. Then you should think about the best possible cosmetic effect for the patient. Then if you want more exposure, you may need to extend the incision. So the initial incision should be placed in such a way that it should allow extension. Then for drainage tubes, there should be separate small incisions. So you can see this is the site of the surgical incision, and this is a separate incision, a small incision that is placed for the drainage tube. The drainage tubes are placed so that the excess amount of fluid and excess amount of blood can be drained in the post-operative period. Now coming to the classification of the abdominal incisions. So there are longitudinal incisions, there is transverse or oblique incisions, and incisions that are not confined to the abdominal wall, they are extending into the thorax, and they are called the thoracoabdominal incisions. These are the different types of incisions that can be placed on the anterior abdominal wall. We will see each in detail. So coming to the longitudinal incisions. There are two types of longitudinal incisions, that is, there is midline incisions and there is paramedian incision. So this is an example for midline incision. This is an example for a paramedian incision. You can see very long midline incision, and you can see this deviation is because you are not cutting through the umbilicus. The midline incisions are placed on the linea alba. So you have already covered what is linea alba. So midline incisions are placed on the linea alba. So what are the structures that are cut through when you are placing the midline incision? Obviously you are going to cut through the skin. Then you have the superficial fascia. You have the two layers of superficial fascia for anterior abdominal wall. That is the superficial fatty layer, which is called the cambus fascia, and the deep membranous layer, that is called the scarpa's fascia. So you have the cambus fascia and scarpa's fascia. Then you have the linea alba. Then you have the fascia transversalis. Deep to that you have the extraperitoneal fat, and finally the paraperitoneum. So these are the structures that are cut through. You can see no muscles are cut while placing the midline incision. There is upper midline incision, there is lower midline incision, and there is a midline incision that is extending along the entire length. So this is an example for midline incision extending along the entire length. Midline incisions can be used for any abdominal surgeries, but they are mainly used for exploratory laparotomy. So when do we do exploratory laparotomy? That is, if you want to examine organs of the abdomen, when the diagnosis is not clear. For example, if the patient after trauma, after a road traffic accident, you are suspecting internal bleeding, then you can do exploratory laparotomy to see which organ is injured. Or if there is a suspected cancer within the abdomen, you can do exploratory laparotomy in these patients. What are the advantages and what are the disadvantages of midline incision? So the midline incisions will give a relatively bloodless field. That is, the linea alba is avascular. So this midline incisions will give a relatively bloodless field, and there is no muscles and no nerves that are cutting. We just saw all the layers, and that muscles are not involved. So muscles and nerves are not cut. But what is the disadvantage? Because linea alba is avascular, the healing is delayed due to the reduced blood supply, and there is high chance for incisional hernia when it comes to midline incision. So that is the disadvantages of midline incision. What is paramedian incision? So the paramedian means it will not be in the midline, it is not in the linea alba, it is slightly away from the linea alba. So these are examples for paramedian incision. You can see this is the linea alba, this is the three oblique muscles, this is the plane in which you get the nerve, this is the rectus abdominis muscle within the rectus sheath. So this is the anterior layer of rectus sheath, this is the posterior layer of rectus sheath. So what are the layers that are cut? You can see the anterior layer is cut, the posterior layer is cut, but the rectus muscle is not involved. So it is an incision that is placed 2.5 centimeters lateral and parallel to the midline. The structures that are cut through in paramedian incision. So we always start with skin. superficial fascia. Then you have the anterior layer of rectus sheath. This is the anterior layer of rectus sheath. The rectus muscle is not cut. Rectus muscle is retracted laterally. This is a retractor. It is retracted laterally. So how is this rectus muscle retracted laterally? The tendinous intersections are divided to free the rectus muscle from the anterior layer, and the rectus is retracted laterally to preserve the nerve that is entering from the lateral side. So you can see the nerve is coming in this plane between the internal oblique and transverse abdominis, seen in the lateral aspect. So in order to preserve the nerve, it is entering from the lateral side of the rectus is retracted laterally. Then you have to cut through the posterior layer. Then you have the fascia transversalis and finally the parietal peritoneum to reach the peritoneum. So these are the different layers that are cut in paramedian incision. And paramedian incision is placed 2.5 centimeters lateral to the midline, and paramedian incision is the most preferred incision. So what are the advantages and what are the disadvantages? So advantages of paramedian incision is better healing. In midline incision, the disadvantage was healing was reduced because of the reduced blood supply. In paramedian incision, since it is not on the linea alba, it has better chances of healing, and also the lateral abdominal viscera can be assessed easily. With midline incision, you cannot go towards the lateral aspect. Lateral organs are difficult to visualize, but in case of paramedian incision, lateral abdominal viscera can be accessed easily. But what are the disadvantages? The rectus muscle is retracted. There can be chances for rectus muscle weakness. We are going to cut through the anterior and posterior layer of the rectus sheath. The tendinous intersections are freed from the anterior layer. So that means there is a chance for rectus muscle weakness. Also, there is difficulty for accessing the contralateral viscera. So if you place the incision on the right side, it will be easy to visualize the organs in the right side. But if you want to visualize the organs in the left side, it will be difficult. So that is the disadvantages of paramedian incision. MAYO-ROBSON incision. So what is this MAYO-ROBSON incision? You can see it is a paramedian incision, but the upper end is extended to the zygisternum. So that is the MAYO-ROBSON incision. Then PARARECTUS incision. PARARECTUS incision is placed more laterally. It is placed over the lateral part of the rectus sheath. In paramedian incision, it was 2.5 centimeters lateral to the midline, but it is on the medial part of the rectus sheath. Whereas in PARARECTUS incision, it is on the lateral aspect of the rectus sheath, and the rectus muscle has to be retracted medially. So in paramedian incision, we are cutting through the anterior layer, we are retracting the rectus muscle laterally, and we are cutting through the posterior layer. Whereas in case of rectus incision, it is on the lateral part of the rectus sheath. We are cutting through the anterior layer, the rectus muscle will be retracted medially, and then we will cut through the posterior layer. And this is called Bartle's incision. So that is the PARARECTUS. Now what are the layers that are cut through? So we have the skin, we have the superficial fascia, you have the anterior wall of the rectus sheath, then the rectus muscle is retracted medially, then you have the posterior wall of the rectus sheath, then you have the fascia transversalis and parietal. The only difference from paramedian incision is rectus muscle being retracted medially. We are not cutting through the rectus muscle, we are only retracting it. And you should be careful not to injure the nerves that are entering in through the posterior wall. So you have to find the nerves and retract the nerves also. The next incision is a TRANSRECTUS incision. From the name, we are going to cut through the rectus. So it is a muscle splitting incision, and it is placed 3 to 4 centimeters lateral and parallel to the midline. So paramedian incision is placed 2.5 centimeters lateral and parallel to the midline. Whereas TRANSRECTUS, we are going to cut through the muscle, and it is placed 3 to 4 centimeters lateral and parallel to the midline. So what are the structures that will be cut? We have the skin, we have the superficial fascia, we have the anterior layer of the rectus sheath, then the rectus muscle is cut like the skin incision, that is, it is cut vertically. Then we cut the posterior wall of rectus sheath. Then we have the fascia transversalis and we have the parietal peritoneum. So these are the structures that are cut when we are placing the transrectal incision. So what is the disadvantage of transrectal incision? We are cutting through the rectus muscle. There is chance for the medial part of rectus muscle to lose its nerve supply. So that is the disadvantage of transrectal incision. Next category, that is the transverse or oblique incision. So transverse incision are transversely placed. Both transverse and oblique incisions, muscle splitting incision. You are going to cut through the muscle. Transverse incisions lie along the Langer's line. So what are these Langer's lines? Also called cleavage lines. These are the lines that represent the direction of the collagen bundles in the dermis of the skin. Langer's lines that is showing the direction of the collagen bundles in the dermis. So you have to put the incision along the Langer's line for better healing. Otherwise, an ugly scar will be formed. So you should have a rough idea about the direction of the Langer's line in different parts of the body. The oblique incisions are directed upwards or downwards towards the flank. What are the advantages of transverse and oblique incision? Since the incisions are put along the Langer's line, so they will heal quickly. Transrectal incisions were not put along the Langer's line. taking more time to heal as compared to transverse incisions. Okay, so they will heal quickly and they will have better cosmetic value. So that is the advantage of transverse and oblique incision. So transverse incisions, what are the structures that are cut through? So you have the skin, superficial fascia, both the recti and the rectus sheath. Then if the incision is extending laterally, the three flat muscles, external oblique, internal oblique and transverse abdominis, all these are also cut. Then below that you have the fascia transversalis and you have the parietal vertebrae. So that is the structures that are cut while putting a transverse incision. So the recti have to be divided transversely in the intersegmental plane, that is between the points of entry of nerves. So between the points of entry of nerves, so intersegmentally you have to cut the recti. So what is the disadvantage of transverse incision? The advantages we saw, there is better healing and better cosmetic value for transverse incision. What is the disadvantage? The blood vessels are cut, so there will be excessive bleeding. You should be prepared to encounter excessive bleeding when you are placing a transverse incision. Fan steel incision. So it is a transverse incision. It's a named incision. Look at spelling, fan and steel. This is a very important incision. It is a transverse incision that is placed just above the pubic symphysis. This is the incision that we usually place for the cesarean section. Nowadays, cesarean sections are done using transverse incision or any gynecological procedure. You are going to place the fan and steel incision that is just above the pubic symphysis. So it gives better cosmetic value, better healing, and better access to the pelvic organs, to the uterus. So it is used for gynecological procedures. So what are the structures cut? With the skin, you have the superficial fascia, you have the anterior wall of the rectus sheath, right and left rectus muscle, and pyramidalis muscle. That is if it is present. I have not written posterior wall of rectus sheath. Why not the posterior wall of rectus sheath? Because you have learned that below the arcuate line, the posterior wall is deficient. So there is no posterior wall of rectus sheath. So you are going to cut through the rectus muscle. You will reach the fascia transversalis. So you are going to expose the fascia transversalis and peritoneum. For intraperitoneal approach to the uterus and the ovaries, the fascia transversalis and peritoneum have to be cut. Whereas for extraperitoneal approach to reach the urinary bladder, transversalis, fascia and peritoneum are just pushed upwards. Whether you cut the fascia transversalis and peritoneum depends upon whether it is an intraperitoneal approach or extraperitoneal approach, which organs you want to reach. So that is the fan and steel incision. This is very, very important. Coming to the Maylard incision. So this is the fan and steel incision. You can see just above the pubic symphysis, you have the fan and steel incision, and slightly above, that is the Maylard incision. So Maylard incision is about 5 to 8 centimeters above the pubic symphysis. Transverse incision that is placed 5 to 8 centimeters above the pubic symphysis, that is parallel to the fan and steel incision. This is also along the Langer's line. So that is the Maylard incision. This allows wider access to the pelvic cavity, and it is also called McInroth's incision. So Maylard incision is also called McInroth's incision. So there you have the two varieties of transverse incision. That is a fan and steel incision, very important for gynecological procedures, and you have Maylard incision 5 to 8 centimeters of the pubic symphysis, also called McInroth's incision. Subcostal incisions. This is the subcostal incision that is placed below and parallel, 2 finger breadth below and parallel to the costal margin. If it is right subcostal incision, this is done for cholecystectomy. What is cholecystectomy? Removal of gallbladder is done with right subcostal incision, and if it's left subcostal incision, you can access the spleen. So splenic surgeries can be done with left subcostal incision. This incision that is done for cholecystectomy, it is called Kocher's incision. So there is the subcostal incision. This is a subcostal incision, but it is on both the sides, right? So this is called Chevron's rooftop modification. It looks like a rooftop. So that is the Chevron's rooftop modification. Okay. Now look at this modification. You have an extension to the thorax. Okay, what will you name this incision? This looks like the Mercedes-Benz sign. So this is called the Mercedes-Benz modification of subcostal incision. Now coming to the oblique incision, McBurney's or gridiron incision. Here you draw a line taking 2 points. That is the right angle is iliac spine and umbilicus. You have to imagine a point that is at the junction of medial 2/3 and lateral 1/3 of the right spino-umbilical line. This point is called McBurney's point. Put an incision perpendicular to it, and an oblique incision made at this point is the McBurney's incision or the gridiron incision. It is right angle to the right spino-umbilical line through the McBurney's point. So once again, you have this right spino-umbilical line, and if you take a point that is at the junction of medial 2/3 and lateral 1/3 of the right spino-umbilical line, you get the McBurney's point, and you put an oblique incision at right angles to the McBurney's point. So that is the McBurney's or the gridiron incision. For which organ will we use the McBurney or gridiron incision? So which organ have you studied over here? You have the cecum and you have the appendix. So it is for appendicectomy. So for conventional appendicectomy, you will use the McBurney or gridiron incision. Appendectomy is one of the easiest general surgeries that are performed. After you finish MBBS and then you do your MS in general surgery, the first surgery that you'll do as a junior resident will be appendectomy. And the incision that you're going to place will be McBurney's or the gridiron incision. McBurney's incision is definitely, it is a muscle splitting incision. What are the structures that are going to be encountered as you put the McBurney's incision? So you're going to cut through the skin. The superficial fascia and the external oblique have to be incised along the line of the incision. We have the skin, superficial fascia and external oblique. These are incised along the line of incision. The internal oblique and the transverse abdominis are split along the direction of muscle fibers. So once you cut through the external oblique, then you have to change the direction of the incision. So that is, internal oblique and transverse abdominis will be split along the direction of the muscle fibers. So that is the structures that are encountered while putting the McBurney's incision. When you are putting this incision, you should be careful not to injure the iliohypogastric nerve and the ascending branch of deep circumflex iliac artery. So you should identify this nerve and artery and be careful not to injure it. It's iliohypogastric nerve and ascending branch of deep circumflex iliac artery. This is the abdomen, this is the left side. So this is the iliohypogastric nerve that is seen in the plane between the internal oblique and the transverse abdominis. So that plane you have to look for the iliohypogastric nerve and you should not injure the nerve. Similarly, you have the deep circumflex artery also seen in this region. So you should not injure these two structures when you put in the McBurney's or the gridiron incision. This is the McBurney's point and this is the McBurney's or the gridiron incision, that is at right angles to the spino-umbilical line. Now, through the McBurney's point itself, you put an incision that is along the Langer's line. That is a modified McBurney's incision and that is called the LANZ incision, incision of LANZ. So, you are putting an incision through the McBurney's point itself, but it is along the Langer's line. Now, if you put a transverse incision through the McBurney's point, that incision will be called Rocky-Davis incision. These are two other incisions that are put. That is, you have the incision of LANZ that is along the Langer's line, and the transverse incision is called Rocky-Davis incision. And the incision that is perpendicular to the spino-umbilical line is McBurney's or the gridiron incision. You can see the gridiron incision is perpendicular to the spino-umbilical line, whereas LANZ incision is along the Langer's line. The transverse incision through the Langer's line near the McBurney point. And that is also done for appendectomy. Different surgeons have different approaches. So some surgeons prefer the McBurney's gridiron incision, some surgeons prefer the LANZ incision for appendectomy. So we have covered the longitudinal incision, we have covered the transverse and oblique incisions. Now coming to the thoraco-abdominal incisions. These incisions are not only confined to the anterior abdominal wall, but they are going to extend to the thoracic region. So it can be either on the right side or the left side. The incision will convert the pleural and the peritoneal cavities into one common cavity. So that is the thoraco-abdominal incisions. Right side thoraco-abdominal incisions are usually done for elective or emergency hepatic resection. Liver is on the right side, so hepatic resections are done using the right thoraco-abdominal incision, whereas left thoraco-abdominal incisions are put when you are going to do resection of lower end of esophagus and the proximal end of stomach. So based on where the organs are, you can decide if you have to put a right or left thoraco-abdominal incisions. This is how the thoraco-abdominal incision is put. This is the left thoraco-abdominal incision. You can see the first incision is an oblique incision passing from the midline at the level of umbilicus. The incision is starting at the level of umbilicus. From the midline it is starting and is extending upwards and outwards towards the costal cartilage of 8th rib. From the umbilicus towards the costal cartilage of 8th rib, and then the incision will pass through the 8th intercostal space. So the incision is extended into the thoracic compartment along the 8th intercostal space. So that is the thoraco-abdominal incisions. So now let us revise. Just look at the numbers and we will see. So this is a subcostal incision, right? Right subcostal incision, that is called the Koch's incision, that is done for cholecystectomy. Then you have the midline incisions along the entire length. Then you have the McBurney's or gridiron incision, that is done for appendectomy. Now this is a pararectal incision, the Battle's incision. This is the Battle's incision. This one is the LANZ incision, that is near the McBurney's point. You are going to put an incision along the Langer's line, and that is also done for appendectomy. This is phalansteal incision, that is done for gynecological procedures called C-section, for taking out the baby. And then you have this 8th is Rutherford-Morrison incision. It is a modification of the McBurney's incision. Then you have the 7th one is a transverse incision, and this one is paramedian incision. This is a paramedian incision, 2.5 cm lateral to the midline. Pararectal is more lateral, paramedian is 2.5 cm lateral to the midline. So these are the different types of incision. This is a scar of a previous incision that is placed. A midline incision was placed. Okay, and now through the scar a hernia has come out. So that is incision hernia. So There is protrusion of intraperitoneal structures through the incision site. What are the different causes for incisional hernia? After surgery, there is a surgical site infection. So that weakens the site of incision. So there can be a chance for incisional hernia later in life. Or if the patient is having morbid obesity, or if there is malnutrition, the healing has not occurred properly, because for healing a lot of vitamin C is required. So if there is malnutrition, healing will not occur properly. If there is diabetes, that can also predispose to post-operative infection. So there can be chance for incisional hernia. Then in the post-operative period, if there is persistent cough or vomiting, there is chance for incisional hernia. Other causes can be if there is an abdominal distension due to ascites. Fluid collection in the peritoneal cavity is called ascites. Again, the surgical site will be weakened. All these factors will predispose for an incisional hernia later in life. Now, what are the surgical management for incisional hernia? Based on the severity, you may have to manage it surgically. You may have to do simple apposition, or you may have to do complex apposition. You may have to use a mesh, plastic fiber mesh, or net closures may have to be used. So this is a mesh that is placed. This is how a mesh looks. Now, if it is above the umbilicus, mesh is placed between the posterior rectus sheath and the muscle. And if it is below the umbilicus, the mesh is placed in the preperitoneal space, that is just in front of the parietal peritoneum. Mesh is placed. Details of this you will be studying when you go to the surgery. So that is about incision hernia. Nowadays, in place of conventional open surgery, a minimum access surgery using laparoscope is gaining popularity. So most of the surgeons, after doing MS surgery, they are going to do fellowships in laparoscopy. 6 months, 1 year courses are there, so that you can become a laparoscopic surgeon. Laparoscopic surgeons are now in demand. So the peritoneal cavity is inflated with carbon dioxide, and an endoscope is introduced through the keyhole ports. You can see so many ports here, 5 ports are there here. Through the small keyhole ports, the endoscope is introduced. So the instruments are introduced through different ports. The camera is introduced through one port, and you are entering into the peritoneal cavity. Now I am going to show you a laparoscopic surgery that is performed for the removal of gallbladder. So that is the cholecystectomy. So you can see here the surgeon has placed an incision on the umbilicus, and now he is going to insert the endoscope by creating ports. Okay, so you can see the abdomen is already being inflated with carbon dioxide, and the endoscope is going to be inserted through the ports. One is through the umbilicus and then through other ports. So now through this he is going to insert the camera and other instruments. So this is another port that is created, and it takes a bit of an effort to insert ports. 3 ports are inserted. Of course, you need to look at the vitals of the patient throughout the surgery. That is the BP, you can see the saturation, the pulse rate. Now they have entered into the peritoneal cavity through the anterior abdominal wall. So while you are entering through the various instruments, you should not injure the organs below. So that is why the abdominal cavity is inflated with carbon dioxide. This is the liver, beautiful liver. This is the right lobe of liver. This is the left lobe of liver, and here you will have the falciparum ligament. Okay. Below, what is this structure that is being lifted? This is the gallbladder. Okay. So the surgeon has held his instrument at the fundus. You cannot see it now. And this is the neck of the gallbladder, and you can see this gallbladder is distended by the gallstones. Okay, now he has to remove the gallbladder. Okay, cholecystectomy. So for that he has to cut the various peritoneum that is covering the gallbladder. Okay, the inferior surface of gallbladder is covered by peritoneum. So you have to separate this peritoneum, and you have to separate the gallbladder from the undersurface of liver. Okay, so now the surgery has proceeded, and the surgeon is cauterizing all the blood vessels, and is in the last step of taking out the gallbladder. Okay, so now the gallbladder has come out. You can see the gallbladder. Now he is going to catch the neck of the gallbladder and bring it out through the port. Okay, through the same port. Now just look at the other anatomical structures. This is the right lobe. This is the left lobe. This is the falciparum ligament. Can you make out the falciparum ligament? This is the diaphragm. Okay, and can you make out? So the gallbladder, he is not able to remove the gallbladder. Okay, because there are stones in the gallbladder. Now he is inserted an instrument, and it's crushing the stones so that you can remove the gallbladder through the port itself. Okay, so you can see the heart is beating. This is over the diaphragm. The heart is sitting, so heart is beating. You can see. Now he'll remove the gallbladder. he has removed the gallbladder. This is how the peritoneum will look under laparoscopy.